In most wealthy countries, if you lose your job, you lose your income. In the United States, you also lose your health insurance. That's not obvious. It's not inevitable, and it wasn't really planned. The fact that roughly half of all Americans get their health coverage through an employer is the result of a wartime tax decision made in the 1940s that nobody voted on, nobody fully anticipated, and that has shaped American healthcare and American politics. Ever since, this is the story of how that happened, why it stuck, and why changing it turns out to be one of the most complicated policy problems in modern government. To understand why employer-based insurance exists, you have to go back to World War II. The U.S. economy during the war was under enormous strain. Millions of workers had left for the military. Labor was scarce. Employers were competing aggressively for workers. And the federal government, trying to control wartime inflation, had imposed wage controls, legal caps on how much employers could raise salaries. Employers needed a way to attract workers without technically raising wages. Benefits weren't covered by the wage controls, so companies began offering health insurance as a form of compensation, not cash coverage. Then the tax system made it permanent. The Internal Revenue Service ruled, and Congress later codified that employer-provided health insurance was not taxable income. If your employer paid you an extra $1,000 in salary, you paid income tax on it. If your employer spent that same $1,000 on your health insurance premium, neither you nor your employer paid tax on it at all. That tax exemption is enormous. It's one of the largest tax expenditures in the entire federal budget, worth hundreds of billions of dollars annually in foregone tax revenue. And it created a powerful, self-reinforcing incentive for employers to offer insurance and for employees to prefer it over equivalent cash wages. Nobody designed this as a national healthcare strategy. It emerged from a wage freeze, a tax ruling, and decades of accumulated inertia. But once it was in place, the entire structure of American healthcare began to build around it. After the war, the system didn't fade away. It expanded. Unions negotiated health benefits into collective bargaining agreements. Large employers used comprehensive coverage to recruit and retain skilled workers. Insurance companies built their business models around group employer plans. Hospitals and doctors oriented their billing systems around the insurance infrastructure that employers were funding. By the time anyone seriously asked whether this was the right system, it was already the system. And systems with this many stakeholders, employers, insurers, hospitals, unions, workers, develop enormous institutional momentum. Each group had reasons to preserve what existed. Employers with healthy workforces benefited from the tax subsidy. Insurers had a stable, predictable customer base organized by employer groups. Workers with good jobs had coverage that, for them, worked reasonably well. And politicians faced the basic challenge that any reform substantial enough to fix the system's problems would also disrupt arrangements that millions of people had built their lives around. This is what policy analysts call lock-in. It's not that the system was ever declared optimal. It's that changing it requires overcoming the resistance of everyone who has adapted to it and whose current situation depends on it continuing. Employer-based insurance works reasonably well under specific conditions. You need a full-time job. The job needs to be with an employer large enough and profitable enough to offer coverage. You need to stay in that job or move smoothly between jobs that both offer coverage. And the coverage itself needs to be comprehensive enough to actually cover what you need. For people who meet all of those conditions, and a significant number of Americans do, the system delivers real value. Employer group plans tend to be cheaper per person than individual plans because the risk is spread across a large pool of workers. The tax subsidy makes the effective cost lower than it would otherwise be, and large employers often negotiate reasonably strong coverage terms. But the conditions for the system to work well are also the conditions that many people don't have. Part-time workers are typically excluded. Self-employed people must buy individual coverage, which is more expensive and less comprehensive. Small business employees often receive worse coverage than employees at large corporations because small groups have less negotiating power with insurers. And anyone between jobs, laid off, caregiving, transitioning careers, starting a business, faces a coverage gap that can become a financial catastrophe if something goes medically wrong during it. The deeper structural problem is that health risk doesn't correlate neatly with employment status. People get sick whether or not they have a full-time corporate job. The elderly, the disabled, the chronically ill, and the working poor are often exactly the people the employer-based system serves least. Which is why Medicare and Medicaid exist as separate programs to cover the populations the employer system leaves out. The patchwork nature of American health coverage is a direct consequence of building a system around employment and then filling the gaps piece by piece over decades. Beyond coverage gaps, the employer-based system creates a set of economic distortions that affect how people work, how businesses hire, and how the labor market functions. The most discussed is what economists call job lock. If your health insurance is tied to your employer, leaving that job carries a risk that goes beyond lost income. It means potentially losing coverage for yourself and your family. for someone managing a chronic condition, or whose spouse or child has significant healthcare needs, that risk is not abstract. It is a concrete financial constraint on career decisions. Job lock affects entrepreneurship. Starting a business means giving up employer coverage at exactly the moment when income is most uncertain. Research has suggested, though the precise magnitude is debated, that the employer insurance link suppresses new business formation because the people most likely to start companies are often also people with families and healthcare needs they cannot afford to leave uninsured. There's also a hiring distortion on the employer side, because offering health insurance is expensive and because the cost is partly fixed per employee rather than proportional to hours worked. There's a structural incentive for some employers to prefer part-time workers who don't qualify for benefits over full-time workers who do. The Affordable Care Act tried to address this by setting a threshold at which larger employers were required to offer coverage, but the threshold itself created a different set of incentives around how many full-time employees to maintain. These are not arguments that any particular employer is behaving badly. They are illustrations of how a coverage system built around employment changes the rational calculations of both employers and workers in ways that go well beyond healthcare. If the system creates these distortions and leaves so many people uncovered, why hasn't it been fundamentally changed? The answer involves several overlapping forces. The first is beneficiary politics. The employer-based system works adequately for a large and politically active portion of the population, people with stable, well-paying jobs at large employers. This group tends to vote consistently and to be skeptical of reforms that might disrupt their current coverage, even if those reforms might be better in aggregate. Politicians proposing major system changes have to persuade people to trade a known arrangement for an uncertain one. That's a hard sell even when the logic is sound. The second is industry interest. Health insurers have built their core business around the employer market. Hospitals, physician groups, and pharmaceutical companies have built their pricing and contracting systems around how employer insurance reimburses. Disrupting the employer-based system doesn't just affect insurers. It sends reverberations through the entire healthcare economy. The stakeholders with the most to lose from fundamental reform are also among the most organized and best-resourced political actors in Washington. The third is genuine policy disagreement. Even among people who agree the current system is imperfect, there are real debates about what should replace it. A universal public system, a public option alongside private insurance, expanded subsidies for individual markets, fully privatized individual markets. These are distinct approaches with different trade-offs, different costs, and different political constituencies. Agreement that the status quo has problems doesn't translate automatically into agreement on a direction. The Affordable Care Act, passed in 2010, chose to work around the employer-based system rather than replace it. It created regulated marketplaces for people without employer coverage, expanded Medicaid eligibility, prohibited insurers from denying coverage based on pre-existing conditions, and required most people to have coverage. It reduced the number of uninsured Americans significantly, but it left the fundamental employer-based architecture intact, partly because replacing it was politically impossible, and partly because doing so would have disrupted coverage for the majority of Americans who already had it through work. It's worth briefly noting that employer-based insurance is not the universal solution other wealthy countries landed on, because they weren't working from the same starting point. Countries that built national healthcare systems earlier in the 20th century, whether through single-payer models, multi-payer regulated systems, or social insurance funds, did so before employer-based insurance had time to entrench itself as the dominant infrastructure. They faced political resistance too, often fierce, but they were building from a different baseline. What most of these systems share is a decoupling of coverage from employment status. Whether you work full-time, part-time, or not at all, your access to health coverage doesn't fundamentally change. The mechanisms differ enormously: how systems are funded, how providers are paid, how costs are controlled. And no system is without its own problems. But the basic principle that healthcare access should not depend on your relationship with a specific employer is one that most other wealthy nations resolved in a way the United States hasn't. This isn't an argument that any particular foreign model would translate cleanly to the American context. Scale, political structure, existing institutions, and financing systems all differ in ways that matter enormously for implementation. But it does illustrate that the employer insurance link is a design choice, an accidental one, not an inevitable feature of how health coverage has to work. The reason so many Americans get their health insurance through their job has almost nothing to do with anyone deciding that was the best way to organize healthcare. It has everything to do with a wartime wage freeze, a favorable tax ruling, and 70 years of institutional buildup that made each incremental change harder than the last. Understanding that history doesn't resolve the policy debate. Reasonable people genuinely disagree about what should replace or supplement the current system, and those disagreements involve real trade-offs about cost, access, government's role, and individual choice. But it does clarify something important. When Americans argue about healthcare reform, they're not just arguing about policy preferences. They're arguing about whether and how to unwind a system that was never deliberately built. That became entrenched before anyone fully understood what it would become, and that now touches almost every corner of the economy. The system isn't hard to change because it works perfectly. It's hard to change because it has become, over decades, the water that too many institutions swim in, and that's a very different problem than a policy that simply needs fixing. This video is for general educational purposes only. Healthcare policy involves complex trade-offs, and the details of specific legislation and programs vary by state and change over time. For information about your own health coverage options, consult official government resources or a licensed insurance professional.